afternoon, professors and colleagues. It's a hard time to have a scientific meeting, but I will give it very shortly. I have three main challenges here. We have to solve these three challenges. One of these challenges is the risk of death and the cause of hospitalization due to hyperkalemia, our trajectory of everyday practice. Second part is towards the ACE and ARBs use, and finally, the renal replacement therapy and the hyperkalemia risk. So we'll have it very shortly. This is my disclosures. So let us have here hyperkalemia is very risky and the sudden death is probable, especially that 98% of the potassium in the body are outside of the intravascular compartment. So patients who presented by hyperkalemia usually have a load of all potassium, maybe 400 or 500 millimole, as well just 1 or 2 millimole rise in the blood or serum. Hyperkalemia is a consequence of any diseases, maybe drugs, maybe declining kidney function, and maybe additional factors. So we have almost always factorial effect, which is a chronic kidney disease and pharmaceutical treatment. So the cardiorenal patients, we are focusing on that. We have to very strict toward the medications available to hold the progression of kidney disease. However, the challenge is to use such a medication like ACE and ARBs with severe heart failure in patients with chronic kidney disease because of the risk of hyperkalemia. We are all, as a nephrologist, panic from the hyperkalemia, and with the first resort, we stop ACE and ARBs, which is a fatal mistake. Just I say that always the patient will die with a normal functioning kidney or with a preserved kidney, however, will die from cardiovascular diseases. So the hyperkalemia is always associated with increased risk of hospitalization, which is more than 3x in patients with CKD or in patients with heart failure. It costs a lot for rehospitalization, and you have to focus on that. Patients with rehospitalization rate is high. There is always a probability of rehospitalization and death. On the same way, we have a swinging between hypokalemia and hyperkalemia. On both arms, it's like a U-shaped. So development of hyperkalemia is manifested mainly in patients with heart failure, CKD, diabetes, and in aggravating by the polypharmacy, which is known to have increasing the serum potassium level, including ACE, ARBs, and mineralocorticoid receptor antagonists. So the guidelines almost emphasize that, which is the very challenge towards the nephrologist is don't wait for hyperkalemia to develop, be proactive, and don't never to stop ACE and ARBs for the possibility of hyperkalemia. There is a lot of guidelines concerning ACE and ARBs and recommendation for heart failure and CKD, and RAS inhibitor increasing the hyperkalemia risk, but still the guideline focusing on control of hyperkalemia rather than to stop ACE or ARBs. So we have a balance between the use of RAS blockade for CKD, and we have a favorable effect, including cardiac involvement, left ventricular hypertrophy, fibrosis, and remodeling. On the same way, we have a beneficial effect of CKD, well known, at least partially, not complete, to preserve the kidney function and to be away from the end-stage kidney disease. On the other way, we have an unfavorable effect like hyperkalemia. We may have additionally acute kidney injury or excessive hypotension. Increasing in that, the potassium, the excretion is lower. Again, it is on the guidelines like KDIGO guideline, European Society of Cardiology, and European Society of Hypertension, and ISN, and all should focus on the first defense and the first weapon against heart failure and chronic kidney disease is the ACE or ARBs therapy. So the KDIGO guidelines saying that for patients with hyperkalemia, newer potassium binder, meaning that not all potassium binder, but what the FDA approval, like here, sodium zirconium, should be used to maximize the use of ACE and ARBs. On the other way, when in patients with chronic or recurrent hyperkalemia, the potassium lowering agent may be initiated as soon as potassium above 5 and maybe above 5.5, but be in this target point. And so administering potassium lowering agent like sodium zirconium, our today for allowing more and more for dosing of ACE and ARBs and cardiorenal protection. So we have a dilemma here. Keep patients on the guidelines and reduce hyperkalemia risk away from stopping the doses of the ACE and ARBs. When we have to stop that, if we are using a lot of oral sodium zirconium and still the potassium level does not drop down to 6, we have to shift it to reducing doses of ACE or ARBs rather than complete stop. Persistent hyperkalemia may have to stop for a while. We call it like a holiday for ACE and ARBs till control. But in general populations, treating that, we have to focus on treating hyperkalemia side by side and shoulder by shoulder with additional potassium sparing diuretics like MRA and the controlling of potassium with control that very frequently and monitoring. So increasing stop race or ARBs will have 2x mortality risk, increasing on the all hospitalization day more who reduce race and ARBs. So managing hyperkalemia by innovations of such a molecule of sodium zirconium, because it's very specific for attracting such potassium in the gut. Why it's a very marvelous effect, we will have that in a second, why in the GIT is a good media to work for the such genius molecule. Because we have here in the physiology that with failing kidney or with kidney disease, chronic kidney disease, there is a control of the bulk potassium receptor in the colon to mediate the absorption or the excretion of potassium. During CKD stages, we have two pathways. We have a feedback control, meaning that increasing in the potassium level will increase the renal excretion. However, with failing kidney, there is a feed-forward control in addition. Once sensing the potassium in the gut is high, then a signal towards the kidney to excrete more potassium. So such a feedback control is disturbed in patients with CKD. Subsequently, physiologically, increased potassium excretion more than 20 to 30% than in normal in patients with CKD. This makes colonic potassium already is huge, reaching more than 20 millimole per liter in such a GIT. So subsequently, we have a molecule to have rapid potassium reduction with sustained potassium control. On the same way, that provides a predictable potassium reduction across patient types. We can have manipulating the doses to control the potassium in the normal level. And such potassium binders are strictly and controllable over a year for controlling of potassium. Subsequently, managing with sodium zirconium, nearly 90% of patients continue RAS inhibitor. And such a patient had double the odds of maintaining RAS inhibitor versus patient not on potassium binder. So this is a good equation to have that, is to maximize the ACE inhibitor and to have the panic away from the hyperkalemia and risk of sudden cardiac death. So this is my first challenge, is the maintaining RAS inhibitor. On the other way, dialysis. Dialysis is trajectory, and you can have seen that only 70 to 100 millimole clearance per session. And if patient is currently going by hyperkalemia before the start of dialysis, the risk of sudden cardiac death increase. Above 5.5 patient starting dialysis session, the probability is maximized and doubled for sudden cardiac death. And this is a very recent publication saying that potassium binder plus dialysate potassium around 3 millimole, which is higher than we are using, can protect the heart from the sudden cardiac death. Traditionally, it is the sort of the potential effect of rapid shift of potassium, making that from minus 90 to over minus 70. So electricity in the heart is augmented. And here you can find that even in all the guidelines that consider potassium binding as an adjuvant to treatment as an emergent therapy, and in patients on dialysis, it works very fastly within 1 hour, and may save the patient from doing dialysis for a simple hyperkalemia as was used in MRA. So increasing the doses and using of such sodium zirconium can adjust the hemodialysis prescription against sudden cardiac death we have to avoid completely low potassium dialysate, and this is limit our potassium movement from the blood to the dialysate, decreasing the overall potassium clearance. Avoid large shift in volume, dialysate cooling, and as well calcium, optimizing calcium in dialysate. One of the great player here is the potassium. So in these cases, we have to demonstrate a trajectory of everyday our practice. If you have a patient with type 2 diabetes, nephropathy, CKD, hyperlipidemia, BMI is 29, serum potassium is 5.2, may be normal. But however, we have to mention that increase of serum potassium by 1 milliequivalent, that means that more than 100 or 200 milliequivalent increase in the total body potassium. So we cannot consider that this number is normal. All the drugs and all the medication should be revised. And in this case, exactly, hospitalization for hyperkalemia is mandatory, and telmisartan and other ARBs have been discontinued as again just for a holiday of the ARBs. In this same way, the medical and the medication history should be revised. In our clinical practice, we always stop ACE or ARBs for a while, just for 1 or 2 weeks if the potassium increase above 6, provided that we are using a potassium binders. If we are not using a potassium binder, so the management will be heroic. So potassium level over time with the ARB, hospitalization, restarting low dose of ARB if it's increased more than 6 millimole, and restarting that from the holiday, we have to continue in ACE and ARBs again for the maximum tolerance and the maximum support. In this another, scenario, 52 years old male with zirconium 10 grams 3 times daily, and on the maintenance, maybe 5 grams and increasing to 10 grams per day with a maintenance dose, we can achieve a high doses of losartan, packet 10 to the patients, and controlling of the serum potassium. With the polypharmacy of the patient and the diet restriction is the hallmark of the use. So in cardiorenal patients, hyperkalemia is an ongoing threat. Guidelines recommend RAS inhibitor for patients with CKD and heart failure, and in addition to treat hyperkalemia to enable patients to maintain an optimal RAS inhibitor therapy. While discontinue or down titrations of the RAS inhibitor carry more risk. So using of sodium zirconium as an FDA approval in that phase. Another case scenario, just 69 years old, she is on hemodialysis and kept on the serum potassium about 5.5 always, especially in the late days of dialysis, which meaning that first week of dialysis, like here in Egypt on first Saturday or Sunday. Subsequently, increasing of potassium will increase the potential of the removal of potassium. A sudden shift of serum potassium will make the risk of sudden cardiac death, which is extremely upon the long period of interval and on the day of dialysis on the first 12 hours. Controlling of that by every other day, sodium zirconium 5 grams, as all the dialysis and other clinical practice had shown that it's more better to have the sustained potassium control in patients on hemodialysis on day after day procedures. So sodium zirconium reduced the need for rescue therapy in patients on dialysis, and responded during the 4 weeks evaluation period with 41% of patients achieved a target potassium between 4 and 5 millimole. And it's generally well tolerated. Actually, in our clinical life, has no even the taste effect or constipation as others, and it can have more or less 4.5 of patients develop hypokalemia, so we have to check that every now and then. So this is my last slide, just recommendations in some countries that use sodium zirconium every other day in between dialysis, just to give the potassium, high potassium pre-dialysis out to between 5 and 5.5 in order to prevent the rapid shift. And thank you very much.